Good afternoon and welcome everybody to today's webinar. We will be addressing the concept of high quality targeted temperature management and how it can be utilized and used as a neuroprotective strategy. I would first like to thank all of you for taking the time out of your day to be here today. Um, and we have a very esteemed speaker here with us today, and I'll be introducing him shortly. Prior to that, let me just give a few housekeeping notes. For any of you who have questions throughout the sessions, please feel free to drop the questions in the Q&A section down below. We will address those concerns, those questions. Some of those questions will be highlighted to Prof at the end of the session so that he can address them personally, providing his own experience and expertise and his own insights on those questions. So feel free to drop any questions that you have at the Q&A section down below. For everyone's information, today's webinar will be recorded and it's only for internal education purposes only. All right. Finally, before we begin, for any of those who would like an e-certificate for today's participation in today's webinar, at the end of the session, there will be a post-webinar survey. At the end of that survey, there's an option to click yes if you would like an e-certificate and to include your full name that you would like recorded on the e-certificate, and then we will send out e-certificates in the next coming days. All right, with all the announcements out of the way, without further ado, I would like to welcome Prof. Shoji Yokobori, Director and Chair of the Department of Emergency and Critical Care Medicine from the Division of Neurosurgical Emergencies from Nippon Medical School Hospital. He will be sharing with us his expertise and his experience having used targeted temperature management for many years and how he has effectively used it as a neuroprotective strategy for his patients. So, Prof, without further ado, the floor is yours.
Hello, everyone, and good afternoon. Thank you. Thank you, Marcus, for introduction. And yes, it's my great honor to be here with you all. Okay, so today's my talking topic is about the TTM in neuro ICU. I share the slide now. Okay. Can you see? Oh, yeah?
Yes, Prof, we can see your slides.
Okay, good. So now we can start now. Um, Again, my name is Shoji Kobori from the Nippon Medical School in Tokyo, and our Nippon Medical School is located at the center of the Tokyo. And so today, I talk about our experience of the TTM in the neuro ICU. So first, let me introduce my institution. Our Nippon Medical School is established in 1876. Almost 150 years experience and history we have. So like this, it's a very unique system in Tokyo and Japan. We do resuscitation and we do the operation by our hand. We do the emergency care and the ICU care, and we bring the patient to the rehabilitation. So like this self-contained emergency medical system, we are providing in our Nippon Medical School. So I hope today we can share our knowledge and experience from the Nippon Medical School. Okay. And today's my talking topic is about these three topics about the TTM for traumatic brain injury. And also the TTM may be beneficial for the internal medicine like a heat stroke. And most important target of the TTM should be a PCAS, post-cardiac arrest syndrome. So today I talk about the regional and some kind of evidence for a TTM treatment. And first, I mentioned about the trauma. So trauma is actually the worldwide problem. So yearly, the trauma, by trauma, the patient died 4 million per year. So we can compare the victim of the COVID-19. So COVID-19, the most of the case was passed away from the by COVID-19 with 6.8 million per 3 years. And victims of the injury is much higher comparing to the infection like as HIV or TB or malaria. And death caused by infection should be almost 4 million higher all over the world. We also can see the incidence of the victims of the motor vehicle accident. So you can see that this map and white area is mortality of the by motor vehicle accident is very low, including Japan and Korea and Europe and Australia, like that. But more deeper, more dark area, like as Africa or surrounding the Asian countries, still high incidence of the deaths by a motor vehicle accident and the trauma. And actually, trauma is 8% of the all-cause mortality all over the world. And this should be the main cause of the death of the younger age. So now we can say trauma is not only the medical, but also the social and the economic problem over the world. And actually, how do we can reduce a number of the dead people? So one of the methods should be a standardization of the patient care. And in Japan, from the 1990s, and we tried to establish the standardization training course for traumatic brain injury and trauma. We say JATEC. So this JATEC is like ATLS in United States or Western countries. But you know that every country may have the different background of the trauma. So we established to be matched Japanese situation. So from the 1990s, we added like these guidelines for traumatic brain injury and trauma care. And now JATEC is added as a sixth edition and in 2024. And also, we established a specialized guideline for traumatic brain injury. So we say the guidelines of the Japan Society of the Neurotraumatology. So this guideline is also established around the 1990s, and within a 30 minutes, this guideline also have fourth edition. So like this, we try to reduce the number of the death by a trauma case and traumatic brain injury. But still, over the world, the number of the TBI is still high, and the number of the death and higher mortality and morbidity in the TBI is a very clinical problem. And I show you the easy table that show the recent clinical randomized control trials for traumatic brain injury from the 2005 and several randomized control trials established from the Western countries. And but about the hypothermia and the temperature management, we cannot see still the good efficacy for a traumatic brain injury patient. And one of the causes should be one of the example is a polar study. And this polar study is established in 2010 till 2017. In this polar study, the traumatic brain injury, almost of the 500 cases were divided as a prophylactic hypothermia and a control normothermia for 7 days. And actually, 6 centers in all over the world was joined, and the primary outcome was a favorable neurological outcome or independent living. And Glasgow outcome, this was measured by a Glasgow outcome scale score at 6 months. But unfortunately, the result is not so good, and we cannot see the good result in hypothermia compared to the normothermia. And actually, the early prophylactic hypothermia could not improve the neurological outcome in severe traumatic brain injury. But like this recent RCTs include the all types of the traumatic brain injury. So as you know, the traumatic brain injury is divided as so many pathophysiology, like as epidural hematoma or subdural hematoma or intracranial hemorrhage and contusion. And we can see this is like as a focal brain injury. And we also can divide as a diffuse brain injury, like as a distal axonal injury and diffuse brain swelling and subarachnoid hemorrhage. But all types of the injury categorized as a GCSS-8 as a severe traumatic brain injury. And actually, the pathophysiology of the traumatic brain injury is so quite different in each type of the injury. So each injury may have each unique pathophysiology. So that's why we uh, include all type of the injury. So this should be one of the cause that we cannot see the good outcome in recent RCTs. And we need to focus on what should I say? It's exact and unique type of the injury. And one of the unique pathophysiology is ischemic reperfusional brain injury in the focal traumatic brain injury. And I show you the easy schema of the perfusion CT. So you see the underneath of the hemorrhage and hematoma, we can see the big area of the ischemia. But immediately after the open the skull and taking off the hemorrhage and doing the decompression, so abruptly brain perfusion is increased, and this also causes the perfusion following from the ischemia. So this ischemic perfusion now brain injury should be in the behind of the subarachnoid ASDH, acute subdural hematoma. And I show you the our experience. So this case was a 6-year-old female, and she was hit by a taxi, and she had a motor vehicle accident, and this was caused traumatic brain injury. But immediately after the coming our hospital, her initial Glasgow coma was 13, B3, B4, and M6. And actually, this type of injury was categorized as a mild traumatic brain injury. But immediately after taking the CT scan, her consciousness deteriorated immediately. Initial CT scan showed the right side epidural hematoma, which is needed evacuation surgery. But unfortunately, heart was stopped caused by a BF and arrhythmia. And she was in CPA, cardiac arrest, and by-brain herniation. And actually, this is my first experience to do an operation for the patient that was in CPA. But we do small bowel surgery to take out the clot and with continuous chest compression. But after the 44 minutes of the resuscitation, her heart was fortunately recovered and returned. And we did definitive surgery after the resuscitation. And then we continued the TTM, target temperature management, as target temperature was 34 degrees for 72 hours. And we provide IBTM, intravascular temperature management by acid classes of medical, chlorine. And we try to keep the heart intra ICP, so uh, uh, intracranial pressure less than 30 millimeter mercury, and we try to keep her ICP with controllable. And actually, she was in 40 days in ICU. And as you can see, that this orange line show the core temperature. And you can see the like this Asahi Kaseizo IBTM can provide us like this so precise temperature management. And then
日々挑戦
she was completely recovered 3 weeks after the injury. And actually now she is in school, junior high school, and doing the sport and studying. So like this sometimes, the oh yes, thank you everyone. Actually, we need to focus the specialized and special pathophysiology like as ischemic reperfusional brain injury sometimes. Okay, and what was behind of the ischemic reperfusional brain injury? So ischemic reperfusional brain injury divided largely as ischemic phase and reperfusional phase. And you can see in ischemia, cellular dysfunction might be occur caused by excitotoxicity and acid toxicity and ionic imbalance. And these also cause elevation of the intracellular calcium. And this also makes activate proteolytic enzyme and caspase enzyme cascade the activation. And this also causes necrosis and apoptosis. But immediately after the reperfusion, immediately after the open the skull and taking care, remove the blood from the cranium. And this will be changed abruptly as a free radical production phase. And this free radical production must be occur within a so rapid duration, like as 5 to 15 minutes. And this also causes damage the protein of lipid and DNA. And this also modulates the neuroinflammation. And this may cause necrosis and apoptosis too. And this boxed arrow show the estimated pathology that may affected with TTM. But most important point should be a cool before the perfusion. I mean the before the free radical production, this timing of the induction of the target temperature management should be much crucial. And according to the like this our knowledge now, Brain Trauma Foundation in United States state that early short prophylactic hypothermia is not recommended for diffuse brain injury, but we still don't know for focal brain injury like the subdural hematoma or epidural hematoma. And this should be, I think, like this ischemic reperfusional brain injury may be a good candidate for targeted temperature management in traumatic brain injury. And with our aim, and we think the target of the IR injury, ischemic reperfusional brain injury, should be reasonable for using the target temperature management. So we organize like this study, and the name is a HOPES trial. And with 9 Japan institute and 5 United States institute, and we provide like this, two RCTs that compare the intensive normothermia versus only early induced hypothermia. So early induced hypothermia mean that before the decompression, we control the patient temperature, patient core body temperature under the 35 degrees Celsius. And we also keep the patient temperature for 48 hours as a 33 degrees Celsius, and we deworm the patient within 40 hours. And then we stabilize the patient temperature again as 24 hours, and we compare the 6 months GOSE. And one example, I show you the one example. This case is a 30 years female, and she tumbled the stairs after drinking. And like this, the subdural hematoma we can see at the first CT scanning. And initial CT scan was a GCS8, E1, B2, M5. And this traumatic brain injury was categorized as a severe TBI. And we do the like this operation, and we keep the patient as a 34 degrees Celsius for 48 hours. And we remove the subdural hematoma, and we also put the intraventricular catheter. And we did a high quality TTM with ZOL IBTM catheter. You see like this so smooth temperature management we can provide for this case. And finally, she could recover as a discharge and 20 days after the admission. So we published this data in HOPES trial in the Neurocritical Care Society journal. And unfortunately, we could not see so many inclusion case, only the 31 patient. But we can see the so precise temperature management in both of the normothermia groups and the hypothermia groups. So you see the error bar is so small. And this is the data and of the final 6 months GOSE score by treatment groups and the normothermia and the hypothermia. Unfortunately, we could not see any significant difference on the favorable outcome. But in hypothermia groups, we could reduce the death compared to the normosarmia. This should be a very big problem, very big progress, I think. We also measure the GFAP and UCHL1 as neuronal biomarkers. And we also can see the GFAP concentration, serum concentration, could see the big significant difference between the unfavorable outcome and the favorable outcome. So in the future, we can titrate, we may be able to titrate the inclusion GFAP concentration. It's okay? Yes, and these days from the China, we can see one more big data from the LTH1 trial. So this LTH1 trial, they compare the longer target temperature management over 1 week and the slowly warming. And they compare the normosarmia and the hypothermia. And this data could show that there are much higher proportion of the favorable outcome comparing between the hypothermia and the normosarmia. Okay, and no significant difference on severe complication. So now we can say the traumatic brain injury, in traumatic brain injury case, maybe target temperature management may be beneficial, but we need to titrate the indication just for unique pathophysiology, like as a ischemic reperfusional brain injury that needs evacuation of the brain hematoma. Okay. And then next, I talk about the heat stroke patient and the TTM, target temperature management. And also the heat stroke is also the very big problem all over the world. As you see, the caused by global warming, the average of the temperature, outside temperature is getting higher year by year. Okay. And heat-related deaths and heat-related illness is also, the number of the heat-related deaths is also increasing year by year. And in Japan, most of every summer, we experience over 1,000 death case caused by a heat stroke. I don't know in your country, but in Northern Asian countries and heat stroke victims, the number of the heat stroke victims is now the social problem, even in Japan. And this is data from the 1960 and from the 1995 to the 1960. So in Japan, especially the elderly cases and no excisional heat stroke case is increasing according to the aging. And most of the 60% of the heat stroke patient is over 65 years old. And I show you the easy schema of the pathophysiology of the heat stroke. And heat stroke caused by, the outside temperature increasing. And this also causes increase in metabolic rate. And this also increases the core body temperature. But if the patient is still in compensable and patient use sweating and increase the cardiac output and try to reduce the core body temperature. But if the patient is over the threshold and in non-compensable patient cutaneous vasodilation and spontaneous vasoconstriction might be occur. And this also causes a decrease of the central venous pressure. And this also causes an increase of the core body temperature. And this may cause, the endotoxemia, like a sepsis and a shock. And this also causes more increase of the core body temperature. And finally, the patient will be in a severe heat stroke status. So most important thing should be how do we can reduce the number of the core body temperature immediately after the onset of the heat stroke. And fortunately in Japan, now we can use IBTM for like this heat stroke. And in Japan, IBTM is approved and covered by a medical insurance from the 2014. And we usually use this cool line. Cool line means the two cooling balloons. And this also the covered by a medical insurance. And I show you our experience of the 85 years old female that suffered a severe heat stroke and yearly. So I mean this case, this 85 years old woman and came twice in 2013 and 2014 in my hospital. But in 2013, as I said, we couldn't use at the time for surface for cooling with IBTM. So we had to do surface cooling, and we add the chilled saline. But you see the cooling rate is so slow. Even 1 hour, the patient core body temperature couldn't reach under the 38 degrees Celsius. But in 2014, now we could apply the IBTM, intraventricular intravascular temperature management, and the chilled saline. You see the so quick reduction of the core body temperature between over the 14 minutes. And she could discharge within 1 week. And this was our great progress that we could use now, the IBTM, for target temperature management for severe heat stroke. And I also published our experience. And this also was a multi-center trial that compare the target temperature management for severe heat stroke. You can see the blue solid line is IBTM, and the red solid line is control. And the control means we didn't apply the IBTM, and just we did a conventional cooling, like the surface cooling or evaporation or like that. And this dot line could show the deviation of the patient temperature. So you see the IBTM, we can see a so precise target temperature management because the deviation is so small. But in control group, we can see the big difference and of the number of the deviation comparing to the IBTM. And we also compare the mortality and morbidity by a CPC and modifier ranking scale. And in control group, the one patient passed away, unfortunately. But in IBTM group, we could see the big tendency of a good favorable outcome comparing to the control, but was not significant difference. So next step for the application of the target temperature management, IBTM, target temperature management should be like this type of the internal disease and heat stroke. So now we are planning to do RCTs for severe heat stroke in Japan. So the future direction of TTM management in neurotrauma and heat stroke, now we can say that consider the target pathophysiology and device and the method. And in target temperature management, in a traumatic brain injury and longer TTM, and evacuated mass lesion should be a good candidate for target temperature management. And yes, actually, now we are in a position that need establish a new RCT in Japan or over the world. So finally, I'd like to mention about the PCAS, post-cardiac arrest syndrome, and TTM management. As I said, the ischemic reperfusional brain injury is a very unique pathophysiology, and also in a PCAS patient. In the ischemic phase, this phase is a cardiac arrest phase. The patient neural cell body and the neuron is in cellular dysfunction. But immediately after the recovery of the circulation, the patient brain should be turned to the free radical production. So as I said, important things should be how do we apply the target temperature management immediately after the patient recovery. And one more important and crucial thing should be hyperthermia, prevention of the hyperthermia. So hyperthermia is said as the worsening factors of the neural cell damage, and from the the several good animal model and basic research. So for example, I can show you the big difference of the histology of the spinal cord injury that compare the spinal cord injury and the normothermia, and the spinal cord injury and hyperthermia. And this light area could show the area of the spinal cord injury. In hyperthermia, the area of the spinal cord injury is much larger compared to the normothermia. So hyperthermia further promote the neural cell damage. So how do we can apply the target temperature management for PCAS patient? So this has so long history from the 2002. In 2002, in a Hacker study and Bernard study could suggest the efficacy of the brain hypothermia at 32 to 34 degrees Celsius. But in 2030, TTM trial could show the no significant difference between the 33 degrees Celsius comparing to the 36 degrees Celsius. So this trial, we say the TTM trial. And after the 2030, the AHA and ILCOR guideline changed the recommendation. As before this TTM trial, the strong recommendation of the American Heart Association was hypothermia therapy at 30 to 34 degrees Celsius in 2010. But after the 2013, the recommend was changed at 32 to 36 degrees Celsius. And actually, the normothermia and the hypothermia, we can choose the target temperature according to the patient severity and the institutional guideline. But in 2019, the Hyperion trial from the United States could show that TTM of the 33 degrees Celsius could be more effective for non-shockable, more severe cases. But in 2021, the TTM2 trial again could show the 33 degrees Celsius and the fever without control the fever. It has no good efficacy. So still in 2020, AHN and ILCOR recommendation is still the same. We can choose the target temperature as a 32 to 36 degrees Celsius, but depend on the physician's mind and appetite. And this is a summary of the guideline, and this shows the pre-TTM2 era. And the recent American Heart Association guideline could show the we need to put the patient in under the target temperature management, but patient target temperature should be between 32 degrees Celsius to 36 degrees Celsius. And we need to keep the TTM at least 24 hours, American Heart Association said. But the recent Costa ILCOR guidelines, and this was also still in under review, but we need to use the endovascular temperature control techniques like the IBTM thermogard of the Asahika Seizol Medical we need to use, and actively preventing fever by target temperature under the 30, controlling under the 37.5 degrees Celsius. And we need to keep the at least 72 hours in TTM and every patient. And Europe recommendation guideline, ERC, European Resuscitation Council guideline, could show the same tendency with AHA, American Heart Association guidelines, as a 32 to 36 degrees Celsius, at least for 24 hours. And Japan too. This JRC is a Japan Resuscitation Council. Guidelines of 2020 also show the 32 to 36 degrees Celsius recommendation for at least 24 hours. So the worldwide recommendation of the each guideline maybe should be a same tendency of the recommendation as a 32 to 36 degrees Celsius target temperature management. But we can check the several previous publication from the 2002 to 2021 from the HACA trial to the TTM2 trial. And the background of the patient is much different among these RCTs. Like the HACA trial, the bystander CPR, the ratio of the bystander CPR was much lower comparing to the TTM1 and the TTM2 that was established in northern area of the Europe, like the Sweden or Denmark. And time to reach target temperature is also have a big range comparing among these publication, like the 8 hours and over 300 minutes. And that's why the 6-month survival ratio was also the differ, like as 18.7. I think that this Hyperion trial was for much severe cases comparing to the TTM1 and TTM2 and the Hacker and the Banner trial. So this will be a very important, and this was learned and lesson from this trial that we learned. I mean, the patient background, we need to think for the application of the TTM in each cases. And that's our rationale of the need of the high quality TTM. And in TTM2 trial, we can see the so rough temperature management. You see that so long line that show the standard deviation. But and after the finishing TTM2 trial, each case was in rebound elevation of the patient temperature, core body temperature. And like this rough control sometimes reduce the efficacy of the TTM. So actually the TTM2 trial, this has some kinds of the problem comparing to our clinical practice, daily clinical practices. So, and actually the mortality is significantly higher if like this overshooting occurs within 36 hours of the rewarming in a PCOS patient. The most important way should be to have the good outcome in a PCOS patient is to control more precisely the patient core body temperature. This should be a good rationale of the high quality target temperature management with using the computed control of the target body temperature and using continuous monitoring of the core body temperature with a broader temperature. Also, we do control of the shivering with a scoring of the bedside shivering assessment scale. So now we can say there is no decision not to perform the target temperature management. Now, in the world, we need more higher quality of the target temperature management, like as the IBTM of the Asahi Kasei Medical. And we also can say that we need to establish more the tailor-made management, and from the one-size-fits-all rough treatment. So you can see, and we can say, and that depend on the severity, and depend on the time from the recovery, and depend on basic initial rhythm, like the shockable rhythm or non-shockable rhythm. We can check the all patient background, and we decide the target temperature, the value of the target temperature as 33 degrees Celsius or 34 or 35 or 36. And I show you the one data from the Japan. And this is published in Critical Care Medicine in 2021. And this trial did measure the severity of the score of the PCOS patient with using the RCAST score. And this RCAST score is the patient RCAST score is more higher. The patient severity will be more high. But the number of the score is when the number of the score